So I'll start again. Good morning, everybody. I hope you are hearing me. So I thank Kirill and all the team for allowing me to share this Congress with you. So it's for a while that we are sharing this ICNS course. And all the time, so Kirill and team, they are trying to get more inventive, let's say, lectures during the course. And so, of course, it's over years now that we are speaking about AVM approach in the venous approach in AVM. And let's say that the first case that we made here, it was 20 years ago, quite 20 years ago. Until now, this technique is not getting democratic because of the fact that Kirill asked me to make this lecture about the angiographic options. So how our technique evaluated. So Kirill spoke about the risks of the procedure, the bleeding risk, and all of these things. And I think now that our risks are reduced thanks to two things. The first thing is the modification of our liquid agent, of course. So we don't have this anymore, this glue, which was polymerizing inside the vessel and occluding completely the vessel. And here, we are not speaking anymore about the pressure cooker technique, because the pressure cooker is to occlude the vein. And here we don't occlude the vein. So you can, when you make the control during the injection by the vein is always still patent. And so this is why we cannot speak about the pressure cooker technique, either if we put coils or we don't put coils. Whatever, so the liquid change and our knowledge by the angiographic evolution, so the evolution on the acquisitions is getting our knowledge better and better in case in order to reduce the risk of the complications. So let's say when we go through an AVM treatment, of course, we have to go through a biplane DSA, super selective imaging, and 3D rotational angiography. So René Chapeau will speak about his 6D acquisitions, but clearly all of this goes in the field of understanding of the venous anatomy. In the past, when we were going all the time by the arterial approach, we were not taking care a lot about the veins, the primary veins, the collectors, and all of these things. We were injecting the liquid agent inside, and we were hoping to occlude the nidus. And we were obsessional with this notion of the nidus and trying to inject by here, and so it will go where it goes, but we were afraid to go through the vein. And so, as Kirill said, so now, if we want to cure an AVM, we have to occlude the vein, because the disease is over the vein, and we have the risk of recanalization if we don't do it. And so the risk of the absence of total occlusion of an AVM when it's treated by the venous approach, and he said it in his presentation, I heard it, is the fact that sometimes we are missing a very small vein which is draining the AVM, and so with time it continues to drain, and this is the kind of failure of total occlusion of an AVM by the venous approach. So we said we have to get an AT and lateral view in the real time of the treatment. Super selective catheterization of the AVM by the arterial approach is really mandatory in order to understand how the veins are connected over the collector itself. So let's say we have the primary veins, and afterwards we have the collector. So we have to know exactly how are the primary veins are connected, and clearly, so we couldn't make a venous approach without making an arterial catheterization, either by microcatheters in order to understand at the beginning, or to inject liquid, as Kirill mentioned, or to use a balloon by the arterial side. But this understanding of the venous phase is really very, very important, especially when you are going through a venous approach. And the 3D acquisition, of course, it will give you an idea about what you did and what you have to do afterwards. So just a kind of image like this, just to tell you that the 3D is not only mandatory in the venous exploration, it's mandatory on the venous exploration, even if you are going by the AVM treatment by the arterial approach. Now, so what we are interested by is this area, which is the nidus area, but we cannot understand anything when we look to the image like it is. It's beautiful to get an image like this, but we don't know where are the abnormal vessels, where are the veins, where are the primary veins. So this is why this kind of image should be treated by the NPR or whatever, but we have to enter inside the nidus with a plan, with a cutting plan, in order to see exactly where are connected the primary veins over the collector. And you will see afterwards, so during the presentation, I will show you how this kind of thing to understand inside the nidus, how the vein is connected, is really important in terms of risk of bleeding of the AVM after the treatment. So, Kirill said it, smaller is the nidus, better is the understanding of the venous system. Clearly. So, we are supported by this paper that we published some years ago regarding the risk factors, the bleeding risk factors of an AVM after a venous approach. And we looked at all the factors. We looked to the venous diameter, the location of the AVM, deep, cortical, whatever. So the only factor that we found, which is a risk factor for an AVM bleeding, is the size of the nidus. And when the nidus is more than 3 centimeters, we have a higher risk of bleeding. But clearly we can understand it because bigger is the nidus, and so less is the understanding of the nidus before the treatment by the venous approach. Now when we are speaking about the venous understanding, it's not this collector that you see on the 2D images. So here we can see that there is a vein. But what we have to understand is clearly what happens inside the nidus itself. And once you make the 3D images, this kind of thing is really very, very important. So when you see that you have here two draining veins, two different draining veins, two different primary veins going from the nidus, it will allow you in such a case, for example, where the arterial access is difficult, to go by the venous access for a partial embolization of the AVM. And it's really very important, and we will come back to it afterwards. So, but we have to prove that those two veins that you see here in pink and in green, that they are totally separated, and once they are totally separated, we are able to make a partial embolization of the AVM by one vein, and in a second session we can go and occlude totally the AVM, because I remind you that so once the nidus is more than 3 centimeters the day of the procedure by the venous approach, so the risk of bleeding is high.
Таким образом, существенным образом снизив риск возникновения кровотечения. Вопросы, которые в связи с этим встают, это куда ставить венозный катетер и сколько вен должно имболизироваться в рамках одной процедуры. Этот вопрос, ответы на этот вопрос различаются в зависимости от конкретного пациента.
This kind of configuration, one efferent vein and two collectors. So we can get multiple efferent veins and one collector, as we can obtain a multiple efferent veins and multiple collectors. And we have to deal with all of this differently according to the length of the veins, the position of the veins, and whatever. So let's speak about it. Let's imagine this AVM. If you look to it like this, so you don't understand a lot of things regarding the venous drainage of the AVM. You can see globally where is the nidus, you can see that you are in a functional area. You know that it's drained by cortical vein joining the SLS, but if you make the 3D images and so you look to the MPR, so you can see that you have only one efferent vein joining two collectors here, so the pink and the blue, so two collectors, so it means that I have only one efferent vein. It means that I don't need to catheterize differently those both veins, and I can go through with only one microcatheter. Here you can see the Apollo, which is in the arterial side, and the Marathon, which is in the venous side. So as neurosurgeon, we dissect the AVM, we put the catheters by the arteries and by the veins, and so in the vein we put only one microcatheter because we have only one efferent vein. And after what we inject the liquid, and here if you compare to the image that you had before, so you have those two collectors joining on one efferent vein, which is the one that we catheterized and we occluded. And here is the control after the procedure. Another example, for example, a tactile AVM. So Kirill spoke about those AVMs of the posterior fossa. So clearly we can understand that we can make a venous approach in the posterior fossa, followed by microsurgery, opening microsurgery. But here we are located on the tactile area. So how to treat an AVM, so to operate an AVM which is on the tactile area. So we have to be completely exclusive inside. In case so regarding the occlusion of the AVM. So now when you look to the 3D, you can see that the AVM has only one tactile AVM, one tactile vein, so which is the efferent vein, drained by two different collectors. It means that I'm not obliged to go through the lateral mesencephalic vein and the superior vermian vein. I have to choose one of them and go through, and I will arrive to the same level. So this is what we did here. So you can see here that we made the 3D, but we made as well the selective catheterization from the artery in order to obtain the configuration of the vein and so the clear anatomy. Here we decided to go by the superior vermian vein. You can see the microcatheter going by the superior vermian vein inside the tactile vein. So whatever from where we are coming, so we will arrive to the same level. And after what we put coils. So by putting coils, as you know, putting coils doesn't occlude the vein that you are treating, so which is draining the AVM. So this is why I'm not really favorable to the appellation of pressure cooker technique. Pressure cooker technique by the vein, it means that we occlude the vein, and the coils alone don't occlude the vein. So if you want to occlude the vein with the coils, you have to add inside glue. And by adding inside glue, here you create a pressure cooker technique. But this one is not a pressure cooker technique because during all the procedure, the vein is still patent. You go backward to the nidus, but the vein is always still patent till you will occlude totally the AVM. And here you inject, and so you occlude not only the AVM, but here you can see the lateral mesencephalic vein is occluded as well. So because it's on the draining vein, and so this is the control. And one of the lessons that we learned during all this time is the fact that if we want to be sure that we occluded completely the AVM, we have to go backward to the artery from the nidus. So even when we are going from the vein, in order to be sure that we occluded the AVM in a safe manner, we have to go backward to the artery and to occlude the artery coming from the vein. And here is the control at the end of the procedure. And you can see that we cued here the AVM, and you can tell me that, so this is another case. So, sorry, I didn't put you the MRI here, the control, so it was on other presentation, I'm sorry for it. So I wanted to show you that even if we occluded here the lateral mesencephalic vein, we don't have a venous ischemia. And so just I would like to tell you one thing, that the risk of the venous approach is in terms of ischemia is much more arterial ischemia than venous ischemia. So it means that when you inject the liquid agent, so if you control your reflux over the microcatheter, so those veins, they are under pressure of an AVM and they are unfortunate functional anymore. The risk is once you are going backward to the artery which is supplying the AVM, even coming from the vein injection. So the injection inside the nidus from the vein is easy and progressive. So once you go to the artery, you have to control this injection, this feeling of the artery, otherwise you can obtain arterial ischemia. So here is another case. So another case where, so this was a case, I think that the presentation of Connie Chapeau is after the mine. So this is a case that we performed during the ALICE meeting some years ago. So this is a posterior fossa AVM drained by two veins. You can see it here. So the arterial catheterization showed us that those two veins are separated in the drainage of the AVM. But here the nidus is small. It's less than 3 centimeters. We said to ourselves, we have to cure this AVM, but in order to be sure that we will cure it, we will navigate through both veins. Here we are in the configuration of what we call two afferent veins joining two collectors. And so, in this case, we go by both veins, so the lateral mesencephalic one and the precentral one, and we occlude the AVM. And if you look on the anterior part of the AVM on the lateral view here, you can see that we filled backward the artery, and so the AVM is totally occluded. And look again to the MRI, you can see that the MRI didn't show any ischemic complication, despite the fact that we occluded the precentral vein and the lateral mesencephalic vein. Again, I'm not saying that we have to get a bigger flux or whatever going to the basal vein or whatever. So here, once you have the vein dilated and as close as you are from the nidus, so you can occlude the vein without thinking about the venous ischemia. Now, where to place the venous catheter when we are navigating by the vein, as close as possible from the nidus, but there is one thing. So if you look to this image, so we have this 3D, you imagine the AVM which is over here, the nidus is over here, you have the big collector here. So you want to navigate inside. So let's see the animation. You can see here that on the wall of the vein, of the collector, you have the afferent veins. So you have the primary, the afferent veins, which are here and here. So the first scenario, if you go inside, so you have to go on the proximal part, you have to stay away from those primary veins which are coming on the collector itself. Why? Because if you want to inject, so everything should be distal to you. This is what we call ourselves the porcelain vein. So everything should be distal, including those primary veins. So if you go in the second scenario by putting your microcatheter too deep inside the collector, so you put your coils or whatever, and you shunt those primary veins which are on the wall of the collector here, and here you will create the thrombosis, here you can create the ischemia, and here you can create the rupture of the AVM. So clearly, we have to understand this configuration inside the nidus just to be sure that we have all the primary veins or the afferent veins which are distal to our microcatheter in order to get them in the retrograde manner than on the anterograde coming from the nidus, because the risk of rupture during the procedure is not really very low. So now, if we come back to this case of the posterior fossa AVM, we can see that the afferent veins are too long. So here on the previous slide, I was explaining how to place the microcatheter proximally. When the primary veins, the afferent veins, are short. Now, if the afferent veins are long like this, it offers you the possibility to go partially through the AVM. Or if you want to go definitely, you have to catheterize both veins because they are too long. And if you want to stay proximally to the bifurcation here, you will be very far from the nidus, and you can miss part of the nidus when you are injecting. So here, if you want to go through, you have to go by both microcatheters and inject the AVM retrogradely. But because of the fact the AVM here was,
располагаться вот таким
let's
вот
say,
образом. Но
bigger than 3
если
centimeters,
у
and we had
вас
the height risk of bleeding
пораженный
if we treat it
участок
in one
больше
session.
3
So in this
сантиметров,
case,
и вы
we can
боитесь
decide
кровотечения,
to make a
мы
partial embolization, like
можем
we show it
выполнить
here, going
частичную
by one
эмболизацию,
microcatheter,
зайдя через
putting
один
the coils or
микрокатетер,
whatever, but we
завести
respect
койлы
the
или
bifurcation, and the
использовать
second part of the
жидкий
nidus
эмболизат и
will be
оклюдировать
drained by
только
the free
часть
vein, which is over here.
пораженного участка, но
So this is
оставив
what we did
одну
here. You can see the coils.
дренажную вену. Вот это
The
то, что мы
bifurcation is
сделали
here. You can
в
see the
этом
coils.
случае. Здесь
One
вы
vein which is
видите, мы
catheterized, and we inject the
выполнили
liquid agent
частичную
retrogradely. So the
эмболизацию с
final control
помощью
of the first
спирали,
session, you
и
can see that the
финальный
AVM is
контроль,
the
вы
part of the
видите,
AVM is extruded
что
with the draining vein, and the other part is drained by a free vein, which is the superior vermian vein. And so after the third session, so after 2 sessions, here we can go and occlude totally the AVM. So you go and you occlude the vein completely. You can see it here. So by putting coils as well, you can go a second time and you can occlude totally the AVM, and you can see it here, and as you can see it here. So this is a recent case. Here you can see the total occlusion of a big AVM, which was judged at the beginning, sent to us from abroad, just at the beginning that it's unsuitable to be treated, and we treat it and whatever. So this is the case of yesterday. So yesterday we made the case, and you can see the result of the
и
AVM.
вы
So
видите результат закрытия артериовенозной
what
мальформации.
we have to take,
И что мы
take home message. I don't want to be very long
должны принять во
in the
внимание,
presentation.
я
Just this is a
не
message that
хочу
I have to give you.
слишком долго говорить об
Understanding the
этом,
nidal
я
venous
хочу
configuration,
вам, чтобы вы
so intranidal venous configuration before any venous approach is mandatory.
доступ
How we can make it by the
сегодня
3D
является
acquisition and by the
обязательным
selective arterial
для
catheterization,
исполнения,
so
если у вас
which we
есть
have to make in each cases, even if we
визуализация,
decided
и вы
from the
можете
beginning to
выполнять
go by the venous
селективную
approach.
артериальную
This nidus size should be as
катетеризацию.
reduced as possible regarding the
Но
publication
для
that I showed you.
качественного
So it
выполнения
should be
данной
less than 3
процедуры
centimeter. So
размер
it's
пораженного участка
clear
должен
that
быть меньше
so it should be
3
as reduced as possible in order to reduce
Почему?
the
Потому что это
hemorrhagic
дает вам
risk,
возможность
because smaller is the nidus and better is the understanding of the vein. So this is the goal, to reduce, mediate, and delay
и это
bleeding.
позволяет
And thank you very
вам
much.
снизить возможности, вероятность возникновения кровотечения. Спасибо большое.